Greetings, everyone. Thank you very much for joining. Professor Lukas will be joining us in about 18 minutes from now. So please feel free to use the chat box and share where are you attending the webinar from. It will be so nice to know where in the world you are right now and watching the webinar. And again, thank you very much for your show, for showing interest in the new series. And after the show, I will also hello. Can you hear me? Please let me know. Okay, greetings everyone. It's so nice to see you here, all of you. Thank you very much for joining us today. And this is Professor Lucas Rasulic lecture. And I believe that you will find it very insightful and interesting. Please use the chat box to share where are you watching us from. And for all the questions and comments, please use the chat box and we will take all your questions and queries during the discussion session. And also, I will be pleased to share a little more about our book, inshallah, and after the lecture and after the discussion session. I hope you will be having. I think many of you have already ordered the book, and those who are in Pakistan already have the book in their hands. So I believe that. All of you know about our work and all the projects that we are still working on, and if there is any suggestion of any topic, please feel free to share it with us and we will be happy to write a book on that topic as well. We will try our best. And as you know, this book is meant for junior neurosurgeons especially, and also for trainees. And it's one of a kind in a way that it is on basic neurosurgical approaches step by step, and you can see that there are so many images, and there are links to for you to access pre-operative videos and lectures and recordings that can be very much easily accessed by scanning the QR code which are given at various different chapters. And also we have added to supplementary notes where we thought there should be some more information for you to know. So we added some special section in this. So I believe that we are still working on it, and I think we will improve it a little more. So thank you very much for joining today. I request you to kindly avoid sharing anything which is more political because it is more a scientific session. So it's my request to please don't share more, anything which is, it's not quite. Nice. Thank you. Yeah. Hello, everyone. So good to see you all here, all the friends and all the wonderful colleagues. Welcome, everyone. It's so nice to see and know you, where are you from, and it's so good to see that nearly from every part of the world we have got attendees, and we are just waiting for Professor Lucas is here, I guess. Hi, sir. Hello, sir. Hi, sir. Sir, we cannot hear you.
Yeah, yeah. Can you hear me now?
Yes, sir, we can hear you now. Thank you very, very much, sir, for joining us today. We are so happy and honored to have you here.
I'm happy too.
Thank you very, very much, sir. It's a real honor to welcome you here today, and thank you very much for spending time from your very, very busy schedule. We can see you all the time, very much engaged in all the educational activities all around the world, and writing papers and promoting peripheral nerve surgery and everything, sir. It's a real honor. You are a real inspiration from all of us, to for all of us.
Thank you. My pleasure. I am uh, very happy that there is a big interest for this webinar, and I'm very happy that I congratulate you for the organization, for your initiative and your enthusiasm in terms of organizing this.
Thank you very much, sir. Honor and pleasure is all mine. And I've always keep the example of legendary teachers like you in front of me. It's always a source of great motivation for me to keep on doing such things. And basically, I really appreciate you. We all owe you so much because it is because of teachers like you that the neurosurgery is still thriving, even in those times when we thought that we won't be able to learn anything during the COVID-19 pandemic. Everything was at a halt. So again, sir, thank you so much, sir. We can see your slides very nicely. I think that if you have some videos to play, you can just give it a, if you want to try, please feel free to try it. And sir, this is a single speaker webinar, so please take as much time as you like, whatever you feel comfortable with, because I always feel that it's a huge privilege for us to have teachers like you with us. So I believe that you should take whatever you feel comfortable with. Sir, if you like, we can start the program now. I just
Well, if you want, we can start now. I mean, this is 8 minutes before scheduled time. So if you want, we can wait other people to join. So this is for me, it's okay. I just join a little bit before in order to check if everything is functioning. So far it looks good. I don't know if you can see my screen,
Yes.
and you can hear me well. So I think we should wait maybe a few minutes for the other people to join.
Thank you very much, sir. Yes, it is also alive on my YouTube channel and also on neurosurgical.tv by Dr. John Bennett. So we've got audience there as well, which is so some of them are there also. But in the meantime, sir, I really thank you so much, sir. Sir, in the meantime, I really want to have the pleasure of saying a few words of your introduction, although you don't need an introduction, but it's a matter of real honor for me to say just a few words, sir. You have got so many contributions with such a well decorated CV that it was so hard for me to pick up what to tell, what to share, because there were so many, literally so many feathers in your hat to miss anything. So, but obviously, just it's an honor for me to introduce Professor Lukas Rasulic, who is the current ENS secretary. He's a full professor at the Faculty of Medicine at the University of Belgrade and the head of Department of Peripheral Nerve Surgery, Functional Neurosurgery, and Pain Management Surgery at the Clinic for Neurosurgery at the University Clinical Center of Serbia. His main clinical and scientific area of interest is peripheral nerve surgery, and he has served as the president of the Serbian Neurosurgical Societies, as well as a founder and a past president and honorary president of the Southeast European Neurosurgical Society. He conducted a Master ENS 2022 Congress, as many of you and many of us have also have the pleasure of attending it. So it was a magnificent event that was totally organized by Professor Lucas Rasulic. I remember that before the pandemic in 2018, I had the pleasure of meeting Professor Lucas Rasulic in Dublin, and there was a lot of hype of attending the ENS in Belgrade next year. But of course, there was a pause because of the COVID-19 pandemic, and I believe it was the first conference of the ENS that held after the pandemic in Belgrade, and there was a wonderful response, and everyone had a lot of interest in it because it was so unbelievably good. So, like I mentioned, he conducted a very really wonderful congress, as well as has served as the chairman of the WFNS committee for peripheral nerve and brachial plexus surgery, and as the chair of the ENS Global and Humanitarian Neurosurgery Committee. He's an initiator in the first year of the ENS section of the peripheral nerve surgery, and he has published more than 550 scientific publications and has contributed several chapters in different scientific books. He's the founder and editor-in-chief of the Noor-ul-Huda, the Serbian Journal of Neurosurgery, as well as the editor, the guest editor, and reviewer in numerous scientific and professional journals. He has served as a faculty at more than 250 international courses and trainings, and has been a speaker at more than 350 national and international meetings, and has organized more than 80 national and international congresses. So it's a matter of real honor for me, sir. I had the honor of meeting you first in Antalya in 2018 during the IBNC course. It was a magnificent course, and I had a great chance of learning from you. It was through your wonderful lectures, and also I had the privilege of receiving a certificate of appreciation for my lecture as a student lecturer there. And from you, I had this still have this picture in my office of receiving that certificate from you. So when I invited you, it was a lot of inspiration there. So again, thank you very, very much, sir, for accepting my invitation and for joining us today and sparing time for your wonderful talk on innovation and research in peripheral nerve surgery. Sir, the floor is all yours. And again, thank you so much for being here.
Thank you for this kind introduction and kind words. I am, as I said, very happy to participate in this webinar, and I'm very eager that a lot of people are joining, as I can see, and I do believe that this will be useful for all participants, at least in terms of raising an awareness and of importance of peripheral neurosurgery within the neurosurgery, and maybe raising an interest for between young neurosurgeons to start doing peripheral neurosurgery. I invite all of you who are interested to learn some more about peripheral neurosurgery to visit my department in Belgrade. We have a nice international fellowship program. So far, around 50 international fellows from 2018 spent from 2 weeks as an observership or 3 to 6 months or 1 year as a fellowship in my department. And all of them now are doing peripheral neurosurgery in their departments. This is one thing and one opportunity. Another thing is to invite you to join us to our educational events and congresses. This year we have in Belgrade. I will tell a few words more in the end of this presentation about these events. To 10th annual meeting of Serbian Neurosurgical Society, which is always, our meetings are always at the end of the October 31st, because it is a day of Serbian neurosurgery. And this year, this event is completely dedicated to pediatric neurosurgery, all aspects pediatric neurosurgery, including peripheral neurosurgery in children. So this is for this year opportunity to come to Serbia, to Belgrade. Some of you have been, and some of you have experience from Serbia, and as far as I know, you are satisfied in these circumstances. I can guarantee the highest level of scientific content and highest level of hospitality and social program to get together, to get more acquainted, and to develop a stronger network between young neurosurgeons all over the world. So it will be my great pleasure to welcoming you in Belgrade this year, like always. Once again, Noor, congratulations for your enthusiasm in terms of organizing all this. And I would now start my presentation, if you agree, since we are approaching scheduled time. It's right now.
Thank you very, very much, sir. Please, yes, please, sir. Please take your as much time as you like, as much time as you feel comfortable with, because we are all here so much eager to listen to each and everything that you share with us. And again, thank you very much, sir, for your very kind dedication for neurosurgical education. Thank you so much, sir. The floor is all yours.
Thank you. Innovation and research in peripheral neurosurgery. This could be understood as something which is science fiction, but now you will see within this presentation that learning peripheral neurosurgery from basic to innovative, you will have a lot of opportunity for innovation and research in peripheral neurosurgery. And it is my great pleasure to present you now some of my experience in Department for Peripheral Neurosurgery, Neurosurgical Clinic, University Clinical Center of Serbia, and the worldwide. Generally speaking, we should all ask why innovation in research. Starting from the beginning of the humankind, men were always eager to improve something, to learn something. Now, in the terms of healthcare and in terms of providing the best quality of treatment to our patients through the mankind, all aspects of innovation and research are on disposal in every field of medicine, especially in peripheral neurosurgery. In peripheral neurosurgery, we are now, beside the standard operative procedure and everything what is necessary for the treatment of this patient on the surgical level, we have a current standing and impact on molecular biology level, which is presented in this presentation, and all this is related to the quality of life and restoration of the function of each individual patient. So no master is born perfect, and the question is, when you are looking somebody who is doing something, is the art in the skill or the skill in the art? And this is something which is steep learning curve, and something which you will become a master through your continuous and consistent work in the field. This is an example how from vascular neurosurgery, how mentor and mentee perform micro suturing. This is example of microvascular anastomosis. This is very similar in micro neural anastomosis, but generally speaking, this is an example thanks to courtesy of my very close friend Jacques Morcos, who is vascular neurosurgeon. You will have to know, beside treating the nerves, also to handle and to take care and to solve different situations, including this kind of reconstruction in your everyday surgical work. So talking about innovation and research in peripheral nerve surgeries, starting from basic through the innovative, we now have a situation that peripheral nerve surgery has been always an ugly duck within all other fields of neurosurgery. And this was many years ago. In the last 10 years, peripheral neurosurgery, especially in Europe, is increasing, and there is increased awareness about importance of peripheral neurosurgery. So this, what you can see now on the screen, is a plenary peripheral nerve session within the major and most important educational event in Europe this year, which is ENS 2024 Congress in Sofia. And you can see that this program is extremely scientific and has strong scientific content. This is something which we illustratively compare with this cartoon ugly duck. Now peripheral nerve surgery is not anymore ugly duck in Europe and all over the world. By the way, I am now in Buenos Aires when I finish my participation in a joint venture between WFNS, ENS, and Planck peripheral nerve session within the Argentinian Congress of Neurosurgery. And many of neurosurgeons, young neurosurgeons from Latin and South America are now very present. This is a strong group in peripheral neurosurgery. So peripheral neurosurgery is now developing all over the world. So this is what is so-called road less traveled. Not many people are doing peripheral neurosurgery. And these are some results of the National Survey of Practice and Patterns and Attitudes in different societies, as well as philosophy of thinking about why should I or should I not choose a field of peripheral neurosurgery to be my field of expertise in the future. And there are a lot of, let's say, controversies in this consideration, especially because you don't have results of your work immediately. You have to wait for the regeneration time frame, and many factors can influence on the final outcome, which are not related to you. So the final outcome can be, let's say, compromised. But generally speaking, if you can see later on, it is worthwhile because results are good and you can really make an influence to the quality of life of your patients and have a strong impact in on their lives. This is a book written by my very close friend Karl-Heinz Land. This is a book. It was written in 2019, 18, published in 19. This is Earth 5.0, Provoke the Future. In that book, Karl-Heinz Land, who is an investigator of the future, already anticipated a lot of development in technology, in molecular biology, in everyday practice, in life, in all fields of life, which is now already ongoing. And this is developing fast and furious. So you will have the opportunity to see in this presentation that in peripheral neurosurgery, you can also have an opportunity to use many of these achievements in everyday practice. This is another story. Another story is related to the essence of peripheral neurosurgery. So simply cutting your nerve changes your brain. When you cut your nerve or you have some insignificant injury which injured your nerve, you are not able to function normally. Not to mention if there is a major, let's say, injury to the major nerve trunks, which disable your extremity to function normally. This is related to the changes in the brain immediately following injury and as well following the nerve repair and reconstruction, which is so-called brain plasticity. And this is a strong impact factor for the final outcome, especially in terms of nerve transfers. So this is something which you also have to have in mind to anticipate in this. Now we are coming to the standard operative procedures. Standard operative procedures in the peripheral nerves repair are direct nerve repair. You can see some examples here on these videos, starting from neurolysis, which is a standard operative procedure practically in all cases. It can be external, internal. Internal has its variation, but you have to be careful in terms when you are performing internal neurolysis not to make an overdoing in these circumstances, not to jeopardize internal vascularization, which can lead to the reverse process in terms of create new fibrosis. There's again, this level is a matter of experience of the surgeon. Then you have a direct suturing. Then you have a split repair when you have a part of the nerve repaired by grafting and the part of the nerve repaired by neurolysis. Then you have a graft repair, which can be complete interfascicular grafting, complete cable graftings, and you can use artificial grafts, conduits, and protectors. And indirect repair, consider nerve transfers, which can be proximal and distal. This is an overview of all transfers which are using in upper extremity reconstruction of the brachial plexus and all other nerves. We'll not now go and talk in all these individual aspects of each individual nerve transfer, but generally speaking, now you have to know that you can help your patient with the distal nerve transfers, even in the cases which relatively recently considered irreparable, such as lower brachial plexus palsy. In this introduction, I would like to present here some of our experience since 1980 in 2020 up to 2023 with a follow-up period of 2 years. We are now preparing the paper of 1,000 brachial plexus surgeries, all types of pathologies, all types of procedures, all types of reconstructive surgeries, which is reflected to the fact that Department for Peripheral Neurosurgery in Neurosurgical Clinic, University Clinical Center of Belgrade is a high volume center. And these are some figures about our experience, as well as a presentation that, according to the European Commission, Department for Peripheral Neurosurgery, Functional Neurosurgery and Pain Management Surgery, Neurosurgical Clinic, University Clinical Center of Serbia, is the officially accredited as a center of excellence in peripheral neurosurgery. It is the only center in Europe outside of European Union. And as I said on the beginning of my presentation, you are all more than welcome to join us for this international fellowship. Again, results are good despite the challenges. In peripheral neurosurgery, there are a lot of factors that can influence on a final outcome. And these are some challenges that you can see that regeneration is slow, Stafford and hazard. Regeneration is misdirected, non-specific, and imprecise. Gap might be too large, considering that this lesion is surgically irreparable. Endoneural tubes cannot be intact, depend on injury grade. Scar and frustrated growth, misrouting, neuronal targeted atrophy, chronic derivation, which means delay in regeneration and restoration of the function, are some of the challenges which can influence on the biological level to the final outcome. Other factors which can be of interest is patient related to the factors related to the patient, because patient must have continuous physical therapy at least in a period of 1 year, especially after complex reconstructions. And this is something which is might be the reasons why many people are not doing peripheral neurosurgery as their field of expertise. But if you consider this point as an opportunity, not as a crisis, not as a challenge, so you can have a real possibility for change and evolution, real possibility for research and innovation, real possibility to impact on quality of life of the patient, and you can have a strong impact on patient satisfaction. This is an overview of general rate of useful functional recovery in all types of nerve reconstruction from our series. Some examples in these videos. As you can see, you can achieve useful functional recovery, which means M3, motor restoration up to M3, and beyond M3, M4 and 5, and sensitive recovery up to beyond S3 to S5 in 92% of in various series. This is 85 to 95%, but in our series, this goes neuralizes to the 92%, direct suturing in 90%, grafting in 88%, and nerve transfer is 72% of patients. So a huge number of patients goes to the better future after surgery. And these are some papers, which are not many in the literature, about quality of life after peripheral nerve surgery and patient satisfaction. So in all of this, you can see that peripheral neurosurgery significantly improves the quality of life. And in one of my papers, there was a survey, and in one question in survey was about would you undergo surgery again if you knew that this result can be achieved, or even better, or even worse? And the vast majority of patients repeat yes. Most frequent etiological factor in different types of nerve lesions, especially brachial plexus traction injuries. Very attractive sport, very attractive regular activity, but leads to the very strong disability. And this is something which you can find in all literature, that it is the most frequent cause of the brachial plexus lesions. These are some of the results of brachial plexus motorcycle accidents presented in upper brachial plexus palsy, which we treated with triple nerve transfer as an standard operative procedure in this situation, which means spinal luxury to the suprascapular nerve via posterior approach, SOMSAC procedure for reconstruction of the from the shoulder abduction, and Oberlin procedure for the elbow flexion. As you can see, these are cases, are some of my cases with excellent recovery. Another story is our sport injuries. We are all in favor of sport. We like to participate in a sports activity, to look sports. We have our favorite sportsmen, but in this situation, most important question is how to help these patients when they get this kind of injuries, and to help them that can restore their function and come back to the field. And especially when you are dealing with professional sportsmen, these requirements are high standard. So you can see here that different situation and can lead to the different type of nerve injuries. Some of the examples in from my practice is let's say humeral shunt fracture during arm wrestling following orthopedic management, and consecutive radial nerve injury, which is most frequent iatrogenic nerve injury. If the patient is lucky and everything is under control, most frequently you are finishing this operation with neurolysis, external neurolysis, decompression, deliberation of the radial nerve. If it is in continuity, you can expect excellent recovery in majority of cases. If the nerve is damaged that require other type of nerve repair, you can then expect also good recovery, but the other factors are influencing on the final outcome, such as length of nerve gap and type of nerve injury, and as well physical therapy after the surgery. Another situation from my practice, another sportsman, professional Thailand boxer. He had knee dislocation and the left peroneal nerve injury. Following the preoperative evaluation, it was a huge 15 centimeters long nerve defect. So the direct repair of the peroneal nerve practically was insignificant and not impossible. You can put long grafts, but the results you cannot expect, especially when you have a late admission for the patients with the peroneal nerve lesions. But you can help this patient with a tendon transfer, and we performed 2 tail tendon transfer, and the outcome 5 months after surgery was significant recovery. Patient was satisfied and he was capable for running, and then still improving in his functional recovery. Another example, with courtesy of my very close friend, Dr. Jorge Clifton from Guadalajara. This is his case. I choose to present this case here because it's very attractive for presentation. He was in the corrida when this happened to the matador. You see the wound of the involved peripheral nerve, so he made immediate repair. He went to the hospital. He made the immediate direct peroneal repair, and with additional tendon transfer at the same stage of the procedure, and the matador had a complete recovery and back to the field 2 years after surgery. This is another second most frequent cause of the peripheral nerve injuries. These are occupational or workplace injuries. Different type of lesion you can expect here. In vast majority of cases, they are associated with injuries of the other systems, vascular, bone lesions, skin, soft tissue lesions. So this is an example of very successful multidisciplinary reconstruction of the brachial plexus and the adjacent tissues, vascular and bony, which means clavicular. We, at the same stage, vascular surgeon, orthopedic surgeon, and myself, we operated this patient in terms of reconstruction of the subclavian artery, fixation of the clavicle, and this was upper brachial plexus palsy. So the only possibility in this situation was to perform grafting from the viable C5 root to the axillary and musculocutaneous nerve with 10-centimeter long graft, and this patient recovered excellent in terms of elbow flexion and good, very good in terms of arm abduction, but he was extremely happy and he get back to his regular activities. He's an auto mechanic, and this is a case, one of in the series of these cases of viable usage of viable C5 in reconstruction of the brachial plexus, which we published in neurosurgery. This is my favorite, one of my favorite. So this patient received multiple proximal peripheral nerve injuries following workplace accident. It was a circular chainsaw injury. So it was injury through the axilla and laceration of soft tissues of the right axillary fossa, axillary artery reconstructed in regional medical center. So he came to me 3 months after injury, and I perform grafting to all major nerves which were injured. All were injured except axillary nerve. So you can see musculocutaneous nerve, 8-centimeter graft, median nerve, 10-centimeter grafts, ulnar nerve, 11-centimeter grafts, and radial nerve branch for triceps, 7 centimeters. I used both sural nerves, and I used the cutaneous branches of the brachial plexus for grafting. And as you can see, 2 years after surgery, he is almost complete recovery. The let's say recovery, which is let's say have a delay, is only related to the ulnar nerve, although he has electrobiographical and clinical signs of recovery even within the ulnar nerve. This is another part of peripheral nerve surgery, severe post-amputational pain. And you have different theories about the different types of pain which patient can face in this kind of situation. We have a strong series of this kind of surgical procedure, which usually now we are doing central anastomosis, resection of the neuroma, amputation neuroma, and central anastomosis, and this usually leads to the significant recovery, reduction of the pain, and as you can see, this patient is very happy. He's playing drums with his prostate. Unfortunately, this is a very well-known situation all over the world. We have a lot of experience in the 90s in the war in the former Yugoslavia. We treated so many patients with the peripheral nerve injuries. Now, situation is the same in a different part of the world. And what you have to know how to treat this type of injuries. These are some of our recent experience in Belgrade. Last year in Belgrade, it was a mass shooting in one elementary school and one village near Belgrade. It was a back-to-back mass shooting events, and these are some patients with radial nerve missile injury, cable grafting, peroneal nerve missile, right sciatic nerve missile injury with cable grafting and right sciatic nerve mesial injury with internal neurolysis. These patients have been operated recently. We still follow them up in terms of recovery. They are young patients, and we hope that they will recover quite well. You have another pathology in peripheral neurosurgery. These are entrapment syndromes, and this is a most frequent surgical procedure in a residency program. This is a cubital tunnel syndrome, and the second one is carpal tunnel syndrome. I'm here presenting my scrub nurse. She was hiding her symptoms from me very successfully, but when I become aware about her symptoms, she accepted the surgery. So I operated her, and I made the complete decompression of the ulnar nerve in all five sites of decompression, and she recovered quite well. And this is very important to understand. Do not underestimate this surgery in terms of it's easy surgery, easy to run, easy to perform, because you have to be very careful in operating these patients, especially in terms of identification and preservation of all branches of the cubital nerve, in terms to avoid postoperative pain, and in terms to have a full decompression in all five sites of the compression in cubital tunnel syndrome. And of course, you have to decide should you do decompression in situ, or should you make a transposition in terms of anteposition of the ulnar nerve in the new position. Then depends on the different situation. This is something which usually now I finish with decompression in situ, and when there are special circumstances like a huge scar tissue or some situation following injuries in this region, then I make some anteposition and transposition. Another situation which is relatively not so frequent, but it's very important, there are tumors of the peripheral nerves. So in this situation, you have to know that you have to receive patient acceptance with full awareness that if you operate this patient, what he can expect after surgery. In these circumstances, when you have this kind of huge tumor within the brachial plexus, you have to, no matter if it is benign completely like schwannoma, you have to do surgery very carefully in terms to preserve all elements and to preserve the function of the whole brachial plexus practically. In cases of malignant peripheral nerve sheath tumors, you have to present the patient that if you perform radical resection of the tumor with a free tumor-free lines of resection, patient will lose his function, which is usually preserved in this situation. And then usually I made the immediate reconstruction of the nerve in this situation. Somebody can say this is an easy case, small ulnar nerve schwannoma in a cubital region, easy to run, easy to remove, benign tumor, everything is fine, and we can do it quickly, and everything will be okay. But you have to be aware that this is not so easy. This is a case of my patient who is a professional flute player, so she needs her intrinsic hand muscle to function very well. So you have to be very precise and do minutious removal of the tumor with a good technique. Now, we are going to the innovation and research possibility. This is not so new. This is something which is already included in peripheral neurosurgery for several years ago. and you have on your disposal to choose. Either you'll perform this kind of surgery, such as decompression of the cubital or carpal tunnel syndrome, either endoscopically, either through the open or mini open, or classical approach. Also, you can do brachial plexus dissection endoscopically. Also, you can do other cases within this improvement in technology. Now you can have a better visualization and better possibility to perform this if you are well trained in endoscopic peripheral neurosurgery. Next level of the game is implementation of the exoscope in peripheral neurosurgery. So microscope is standard. Loops are okay. If you are doing with the loops, you have to have a good loops with good magnification. And if you don't have a microscope, you can do this kind of surgery with a simple magnification, simple intraoperative monitoring or stimulation, and simple instruments, and you can achieve good results. But we are now talking about high level of activities in this field, which require latest advances in technology and science. So exoscope is now practically knocking on the door and coming into the field through the big door. And this is some of the papers which are presenting good results in terms of usage of exoscope in peripheral neurosurgery. In the field of imaging, now MRI is a standard in preoperative evaluation and even in a postoperative follow-up, because thanks to the technological advances, you can have DTI measurements, you can have a fiber tractography, you can see structural and microstructural evaluation of each individual nerve, each individual element of the plexus. And finally, you can see all lesions, as well as you can see relationship of these lesions with the nerve elements. And the end, you can see also regenerative fibers with a 7 Tesla MRI. This is one of my favorite slides. So you see, machine is doing the same with the same precision as the man. So what we can expect in the future? Should machine operate these patients instead of men? This is already in the field. So Da Vinci robot is implemented in field of peripheral neurosurgery in several centers, especially Brazilian group of neurosurgeons who are doing peripheral neurosurgery. They already published a series of patients operated in terms of reconstructing of the upper brachial plexus palsy using SOMSA procedure and Doberlin procedure with Da Vinci robot. But this is a more general surgical device. What I would like here now to present here is Simani surgical system. This is the latest advance of the robotics in peripheral neurosurgery. This is directly focused on microsurgical reconstruction. This I have the opportunity to use this. I don't have this Simani surgical system in my department, but I have the opportunity to work in this in Hanover, and this system enables precise movements that can reduce errors of vessel or nerve trauma during suturing. It's particularly designed for nerve and vascular micro reconstruction, and additionally, this system is designed to follow your motions and to enable motion scaling, which translates natural microsurgeon movements to nano wrist micro instruments, which is very important for highest precision in microsurgery. So, education in peripheral neurosurgery, as I said on the beginning, consider steep learning curve from basics through advanced steep learning curve, following to the complex cases, and at the end, a lot of possibility for innovation and research. Starting from education of the, let's say, basic level, you have now possibility to perform this cadaver-free education. You have possibility to have a 3D models in terms of learning anatomy. You have the possibility to perform this kind of exercise in terms of placement of the microsurgical anastomosis. And this is very important to animal-free. And this is something which is very important to determine your time for practicing in this, because you cannot have time to practice in the OR. When you can enter in the OR, you have to be ready to perform this, following the guidance of your mentor and strong monitoring in terms of until you achieve this kind of skill that you can do it by yourself. Factors that are limiting successful peripheral nerve regeneration is our target. So current standing on the molecular biology level are focused and directed to these aspects of peripheral nerve surgery. So in older age, you have a limitation for the patient that previously in some books and papers, it was written that upper age limit for the nerve reconstruction is 60 years. So patient older than 60 years cannot expect successful regeneration following your nerve repair, which is nowadays completely not true. Then time elapsed since the injury. So with so-called late reinnervation of the nerve. This means a period of 12 months was considered as a end period because of the definitive fibroatrophic changes in the motor plate and the muscles which are receiving regenerative fibers due to the atrophy. But nowadays, this is also changed in terms of extension of this time up to 18, even to 24 months, including if you are, let's say, have clear signs that the muscle is still viable at the minimum. And you can try to fix this in terms of using all this, what you have on in your armamentarium for improving the function of this patient. Another problem is long distance to the target organ, which means misdirection of the regeneration. And this is in terms of large nerve defects. This is something what we are working on that. I mean, investigators all over the world are working to overdo this kind of problems, which you can have in some situation. These are some factors which are promoting misdirecting of the regenerative fibers. And this is anatomical aspects and anatomical variability in a fascicle spread proximal to distal. Then each individual nerve has a certain number of nerve fibers. And this number can variate plus minus, but generally, if you are lucky or your patient is lucky to receive 30 plus of regenerative fibers to achieve the end organ, this you can expect useful functional recovery. And these are the situation when we are doing something in terms of have an impact to overcome this situation, such as unpredictable direction of regenerative axon spread. So these are experimental strategies for peripheral nerve regeneration, which are now focused through the pharmacotherapy, cellular therapy, tissue engineering, advanced biomaterials, physical therapy, and gene therapy to neural growth, to site of nerve injury, and to the target organ. So this is something with what is in let's say experimental level, developing very fast in terms of having a possibility and product which you will implement during your surgery and or following surgery in terms to complete augmentation of nerve regeneration. These are some of the strategies for impacting on the molecular level, and they are on the basis of pharmacological, cellular, physical, and genetic level. So you have phototherapy, you have electrical stimulation, you have medicamentous therapy, you have stem cells, you have a gene therapy. This is something many of you, including my department, don't have all these possibilities on disposal. But we are now talking about innovation and research in this field. You can do successful peripheral neurosurgery in your department without everything of this. You can do with the simple instruments, you can do with your knowledge of microsurgery, with your knowledge of anatomy, and you can achieve good results. And I want to encourage you to do this beyond all these latest advances in innovation research of peripheral neurosurgery. But this is a presentation which I want to present you, that in this field, which is maybe ugly duck, as we discussed at the beginning, you can have a full lifetime possibility to do everything or whatever you want, depending on the situation where in which you are. Another possibility is artificial nerve grafts, and this is related to the structural design, material characteristics, and functional cues, which is now on the level of 3D printing nowadays. And this all grafts, artificial nerve grafts, can have different aspects, but generally speaking, they are still on the experimental level and trying to, let's say, develop the best possible product which can replace autologous graft, which is usually sural nerve, in nerve repair of the small nerve defect. Usually, nowadays, we use actual these artificial nerve grafts conduits in nerve defects which are shorter than 2 centimeters, and the cross diameter of the peripheral nerve is less than 10 millimeters, is not bigger than 10 millimeters. And they are initially designed for the reconstruction of the digital nerves. This is something what we are doing in Serbia. My fellows are doing this in the lab in terms of developing experimental 3D printing in Serbia, then implementing in the rats, and then make a follow-up, and then following the ethical approvals and everything in terms of implementing this in some situation in a regular basis during the surgery. But this is also nowadays on the experimental level and still remain a long run. This is the question. Artificial full nerve can be produced somehow. Will it be possible, including 3D printing? You have some in United States in some situation you can have a cadaveric nerve which is decellularized and prepared for the diminishing of the autoimmune response of the patient in terms of repairing of the large nerve defects. And this is something what is doing in a rare situation, especially in the nerves with a large caliber. But this is also not in everyday practice so far. But generally speaking, everything is focused in that direction to create something which is will be artificial nerve to replace autologous nerve grafts. To restore the function in the situation when the lesions are irreparable or you do not achieve useful functional recovery. This is something which is now very interesting in everyday practice. This is first clinical trials in use this exoskeleton for within the implementing of neural links in humans to achieve restoration of the functions and even movement of the extremity which was completely paralyzed. As you can see, this is something which can be very soon in the market, and the patient can have a better quality of life, a better functioning with the implementation of these systems. Everything is based nowadays on the artificial intelligence. You all of you, I'm sure, use, including me, use ChatGPT in terms of helping us in for doing things, and this is something which is largely used in life, but generally speaking, also in the peripheral neurosurgery. So this is something which can, in future, also have a strong impact for achieving better outcomes in our patients. This was one of my favorite slides in many of my presentations. I put this slide here because this is something which is still actual, but now, thanks to the better understanding and the raising an awareness of importance of peripheral neurosurgery, this is not so actual in terms of repeating this every day in everyday practice, but still there are the facts about peripheral neurosurgery and there are the myths. And because of the wider audience in this webinar, I would like to repeat the facts that peripheral neurosurgery is not a life-saving surgery, is not a replantational surgery, is a reconstructive peripheral neurosurgery of nerve reparation, is elective surgery, except in rare occasions. You have to know anatomy and systematization, pathophysiology, and pathoanatomy very well. Operations are usually long-lasting, demanding and in a minutious work on nerve tissue. Surgeons have to be patient and persistent. Peripheral nerve injuries are associated with bony and vascular structures in general, which require multidisciplinary approach to this patient. Recovery after surgery is very long-lasting. Recovery is influenced by the type of injury, microsurgical technique, length of nerve gap, physical treatment, patient's motivation, and persistence. Physical treatment is mandatory. Multidisciplinary approach is mandatory, as it is as demanding, as important as a vascular or skull-based or spinal neurosurgery. Significantly improves patients' ability to perform everyday life and professional activities, improve the quality of life of the patients, and learning, training, and performing the peripheral neurosurgery is worth of pain. These were the facts. And the myths which are overcome, that it is deficit after peripheral nerve injury is permanent and irreversible. Peripheral nerves are unable to regenerate. Plastic surgeons and orthopedic, not neurosurgeons, perform peripheral neurosurgery. Patients and surgery is a second line. Less valuable and less useful surgery, easy to perform, neither attractive or worthwhile. surgical treatment results are not achieved and they are not significant anyway, and obstetric brachial plexus palsy is not surgical treated in Serbia. That was a myth that we overcome many years ago. So this is just for the wider audience. So still in everyday practice, because of the importance and the, let's say, wideness of this field and all aspects which are related to the peripheral neurosurgery, from the biological through the technological, surgical, and up to technological level, still there are no class 1 evidence based in the literature in terms of what you will do in each individual patient as a standard procedure for every case. Still, we are on the level of coin flip based decision making as a matter of interoperative finding and surgical experience. Although you have a lot of papers in the literature, especially in the last 5 years, the increased number of the papers in the literature regarding peripheral neurosurgery is unbelievable. But generally speaking, there is no double-blind randomized studies which you can conclude for a class 1 evidence-based. So you can base your decision-making process on this, and then that's why you have to have some of this experience. These are top 10 reasons why neurosurgeons should do peripheral neurosurgery. 1, it is neurosurgery. 2, you have to know knowledge of neuroscience in all aspects, as I mentioned. 3, you are handling the nervous tissue. 4, you have to have microsurgical skills. 5, possibility for education and research are obvious, as you could see in my presentation. 6, steep learning curve, which is like in every other field, but it is worthwhile. 7, lot of innovation, like in every other field, but fast and furious innovation. 8, results are good. 9, you can impact on quality of life. And 10, you have an opportunities and possibilities to perform this, as I said, with simple instruments, with a simple magnification, with a simple monitoring, neurophysical monitoring. You have possibility to perform this in a public or in a private practice. So this is a full-time job. These are top 10 problems in peripheral neurosurgery. I will now list all of them, and some of them are mentioned. 1 is later innervation. 2 is facial reanimation, which is also very important and big challenge. Another is vocal cord paralysis. Another one is keratopathy. Another one is frozen section of the proximal stump. Should we perform proximal in every case? Intraoperative histology in terms of frozen section to confirm that the stump is viable or not. The possibility to improve nerve transfers are also big challenge. Then these rare symptoms such as anterior cutaneous nerve entrapment syndrome, and as well as cluneal pudendal nerve neuralgia, meralgia paresthetica, which are piriformis syndrome, etc., which are completely controversial, especially in terms of their pathophysiology, still remain a big challenge and problem in peripheral neurosurgery. Another story is are tumors, especially malignant tumors, which can be associated with other syndromes. And this is something which is also a big challenge in peripheral neurosurgery. And finally, augmentation of nerve regeneration was mentioned in my previous talk. So in conclusion, none of the nerves will recover the same. And this is absolutely my experience, and not only mine, but experience within the experts all over the world. Class 1 evidence-based strategies are still matter of further double-blind randomized cohort multicentric control studies. Surgeon decision based on knowledge and experience is a predominant impact factor. And hand of the surgeon, irreplaceable, remains, in my opinion, still remain irreplaceable factor despite how the world would like in 21st century. And this is an essence of peripheral nerve surgery. Keep it simple, surgeon. So you should cover simply your clinical history and exam and the simple foundation of diagnostics in peripheral nerve surgery. You should keep the indication for surgery simple. You can try conservative measures, but you have to decide on time your indication. Make the surgery simple, avoid complication. Neurosurgery can be done with the simple basic instruments. And if you have complication, accept it and deal with them. And these are the tasks with which group of very devoted neurosurgeons all over the world define in terms of worldwide education process, considering raising an awareness about peripheral nerve surgery and the importance of peripheral nerve surgery, especially in low and middle income countries, which can be done online, which can be done on site, in terms of accepting residents in for international fellowship, or coming in the institution and regions and the countries to perform this kind of education. So this is all on your disposal. You have to just contact me or anybody else in terms of helping you to achieve this kind of education. And hopefully you will start working on the peripheral nerve surgery field in your institution, in your countries, and develop strong centers and helping your patients as well, educate younger colleagues and create a strong team. This is my also one of my favorite slides in all my presentations, which finally can result in terms of if you are consistent and persistent in your efforts, you can achieve success, and then you can become a leader, and then you can have your team. And this is a slide which I related to my team, my younger colleagues in my department, who are now surgeons doing peripheral nerve surgery quite good and working to improve themselves in the future. So when you come in my department, you will see all of them, and this is something which I would like to express my gratitude to all my team, which is working with me for more than 30 years in this field.
And I am with the force.
And for the end, may the force be with all of us. May the force be with you in your willingness to learn, willingness to improve, willingness to grow, and to do whatever you are doing, no matter if you are choose peripheral neurosurgery or any other field of neurosurgery. Do your best, and you will achieve the best. Finally, at the end, I would like to cordially invite you to the series of educational events with a lot of peripheral neurosurgery, which will happen in Europe, in the Balkan region, particularly starting with 6th Congress of Southeast European Neurosurgical Society, joint venture with 25th Congress of Hungarian Neurosurgical Society in Budapest from 9 to 11 October. You have all this on your websites. This is a major neurosurgical event this year in Europe. You saw the beginning program of the plenary session of the peripheral neurosurgery, which will be in this Congress in Sofia, Bulgaria, October 13 to 17, European Association of Neurosurgical Society 2024 Congress, which is related to innovation, education, and leadership. This is opportunity for all of you to join and to see a lot of about not only peripheral neurosurgery, but all aspects of neurosurgery. And finally, this hot or red October is finishing in Serbia with 10th Serbian Neurosurgical Society annual meeting with international participation, which is completely related to the pediatric neurosurgery in the 21st century challenges and opportunities, including pediatric or peripheral neurosurgery in children. This is from October 31st to November 3rd in Belgrade, Serbia. I cordially invite all of you to join us. I can guarantee for highest scientific content level and also good hospitality and excellent social program. And this is how it works. This is my mentor, Professor Miroslav Samaric, who's merit in making Belgrade School of Peripheral Neurosurgery on the international map is of outstanding importance. So these are two of us through the time, sometimes in 1996, sometimes through 2000, and when he was retired in 2013, I would like to call this photo "What Surgery Done to a Man." He is now almost 80, and he looks the same. We are in a good shape. We are working together in academic level and communicating regularly. And you can see me. So life is not fair sometimes, but surgery, and you have to give your full of your capacity to this field.
That's all, folks.
So thank you very much for your attention, and I would like to believe that this presentation is useful for you, and you can find something interesting for your everyday practice.
Thank you so much, sir. It was an incredible lecture, and the whole chat box is full of wishes and greetings and big thanks and appreciation for you, sir. And we've got audience from all over the world and from every continent, and so it's a huge pleasure for us to welcome you and to have this privilege of listening to your so much insightful lecture, sir. I can see that the whole chat box and even my WhatsApp is full of a lot of messages, and everyone is sending you wishes and greetings and a big thanks. So again, sir, thank you so much. There are a couple of questions in the chat box as well. Sir, you have very nicely mentioned and elaborated each and everything, for which we are so much grateful to you, because I believe this is a very, very important topic, but it is rather, we need to be more cognizant of this, and we need to teach it a little more. So thank you very much, sir, for highlighting this very important topic. Sir, there is just a couple of things that we might like to know from you. Sir, what do you think about the role of stem cells in peripheral nerve injuries? Do you believe there? How do you see the stem cells in peripheral nerve injury?
Can you repeat once again, please, your question about? Can you repeat the
Sir,
question?
stem cell therapy. Yes.
Stem cell therapy, first of all, can have some impact, but the main issue is that you don't have this on disposal easily, and this is something which is now organizing to have a product which can be used in direct implementation during the surgery at the same stage within the nerve and in the field, and then to implement also in the denervated muscle. So this is something which is now still in experimental phase in peripheral neurosurgery. It has some influence, like in other field, in terms of improving the regeneration, but still it's working on this.
And so there's also, the role of exosomes. So do you think that, how do you see the exosome therapy? Exosomes.
Once again, please.
Exosomes, sir, the exosomes. How do you see the exosome therapy? Exosomes.
Yeah.
Yes.
So, as I said, this is all about innovation and research level. This is not in standard
Mm,
practice in vast majority of centers.
mm.
You can do it in a experimental level, still only now on animals. You understand?
I believe similarly, the engineered conduits, the NGCs that have been introduced. I've read about a lot of about
I,
I think
I believe this will be very soon in everyday practice. Artificial content. If you ask me about this, and it will
yes,
be very soon.
exactly.
No, there are already now in the practice. We are using them, some of them, but
Yes.
you have some problems. Let's say when you put, let's say, graft is length of the fact is more than 2 centimeters, 2.5 or even 3 centimeters. Then you have a already conduit which is 3 centimeters long, and this is the nerve diameter is less than 10 millimeters. So why should you use this autologous nerve, sural or whatever sensitive nerve? You should put this artificial conduit, but this appears you in the practice and literature that there are not good results if you put only this conduit. Then there are also now attempts to fulfill the conduit which is empty with let's say remnants of the fibrous tissue with which contain also nerve tissue to fulfill this diameter of the conduit in terms of prevent misdirection of the regenerative axon from proximal to distal. This is also not so shows that there are not so there are some good results, but not in a highest level as you could expect. So now this all what we were talking is now working that you will have a product which is artificial conduit, which will be practically ready to implementation, just as an a vascular graft, to put it in the nerve gap to make stabilization of suture line and substabilization of suture line to fix it. And inside it will have a, let's say, field, I mean, tissue, which will be consisted of all these elements which are improving and augmenting nerve regeneration. And this is something which is, I believe, will be very soon in everyday practice.
That's amazing, sir. Thank you very much. So there's also some, interest in the thread ultrasound guided, carpal tunnel release. Sir, there are a couple of, papers on it, and there are a couple of eminent centers who have shown that it is a very successful, technique, the thread ultrasound carpal tunnel release. Sir, how do you see this technique for carpal tunnel?
Ultrasound is nowadays practically conditio sine qua non. If you are doing peripheral surgery, you use ultrasound preoperatively. You can use high resolution ultrasound even intraoperatively, and you can use high resolution ultrasound postoperatively in terms of not following only possible thrombosis or something in the vessels, but you can have it in terms of following even nerve regeneration. You have a high precision ultrasound, which are very precise. And for example, in obstetrical brachial plexus palsy, in a small children, babies, practically 3 to 6 months, some surgeons are not performing MRI at all. They are performing only high resolution ultrasound with highest precision. So ultrasound is very important tool in peripheral neurosurgery.
Thank you very much, sir. Sir, I think that it's a very huge talk, and you have already elaborated almost everything, more than everything, I guess, that we need to know. So again, thank you so, so much. But there are, there are so many papers talking about magnetic stimulation and electrostimulation, etc., all these options. And even some of the papers are also endorsing herbal therapies like, ginkgo biloba, and, even curcumin, that has been extracted from turmeric and etc. So I guess there's a lot of things which are available now, and I think everyone is working on something, proving something new in this field, which is quite interesting. Although, like you have very nicely said, but I think the basics remain. That the basic is how you know about the basic surgical technique as a neurosurgeon. Sir, there are a couple of questions. Would you like me to share them with you?
Yes, yes, please.
Thank you very much, sir. Sir, there's a question from Professor Gabriel Vargas from Bucaramanga, Colombia. Sir, he is asking, what is the best strategy for treating chronic pain after severe brachial plexus injury?
What is the best strategy? Once again, what is the best strategy for?
What is the best strategy for treating chronic pain after severe brachial plexus injury?
This is a very important question, and this is a very serious problem. And my answer to that question is the best strategy for treating chronic denervation pain in brachial plexus injuries is that one which helps patient the most, because there is no standard. As I mentioned, there is no class 1 evidence base for decision making for the parameters of decision making process in choosing of treatment strategy. This is the same for the choosing treatment option in treatment of chronic denervation pain. So you have to try everything to help your patient and to find what suits him the best, including, I don't believe practically in DRES, but maybe DRES in some situation can help the patient. There is in let's say last few years increasing interest for neuromodulation in spinal cord stimulation, and including neuromodulation in treatment of chronic denervation pain, which is still in experimental phase, and might this can also be useful for the patient. But generally speaking, you have to. This is a big problem. You have to take care about this patient very carefully and very individually. So you have to tailor your approach to this patient and to find the best possible way to help him with this pain. And you have on your disposal different types of possibilities, different treatment modalities, and you should try them all.
Thank you very, very much, sir. Sir, there are so many wishes there, and Professor Kemal Ghotme from Colombia also is also sending you. Professor Kemal Ghotme, I think he's from, he's from ISPN, a very active person and a very wonderful friend. Dr. Kemal Ghotme is sending you wishes for a masterful talk. Congratulations and many thanks. And Professor Gabriel Vargas are sending you huge thanks. Sir, there is another question again. Are any of these applicable on lower cranial nerve injuries and repair? Is any of these techniques applicable on lower cranial nerve injuries and repairs?
You have to repeat your question, please, because this I
Yes.
cannot catch every word. So just
Yes.
repeat also with the question in the chat list.
Thank you very much, sir. Actually, my internet connection, we have got some issues right now in our internet, so I'm really sorry that there might be interruption from my side because I'm really
It's
yes.
okay.
Are any of the techniques you have taught in the lecture applicable for the repair of lower cranial nerve injury? The lower cranial nerves, can they be repaired from any of the techniques you have mentioned?
Cranial, are we talking now about the repair of the cranial nerves?
Yes.
Yeah.
The lower
So,
cranial nerves. There's a question. Yes.
oh, no, yeah, lower cranial nerve. So lower cranial nerve, one of the most frequent lower cranial nerve, which is repairing if it is lower, because it is most frequently matter of nerve repair is a facial nerve. So for the other cranial nerves, in terms of lower group of cranial nerves, there are not so many direct injuries, but the let's say rules are the same. The best possible treatment is direct repair at the moment of lesions, like Professor Sami recommend reconstruction of the facial nerve in the following the removal of the schwannoma, vestibular schwannoma in the CP angle. You if you find at the moment that there is a lesion and you have a proximal direct stump, you have to be careful because the cranial nerve do not have epineurium. They practically have only perineurium, so you have to avoid microsuturing. You just have to place a small graft in this defect if you can see this. And there are some cases, I have also some cases in my practice when I was invited to reconstruct the facial nerve in the operative field following the vestibular schwannoma removal and lesion of the facial nerve with the proximal distal stump. You just place the small graft to 1 or 2 centimeters in the place, adjust the proximal distal line, put some fibrin glue, and that's all. You are not placing microsurgical sutures. Same can be applied to the other lower cranial nerves, but you don't have the opportunity to fix all these nerves if they are injured directly endocranially, intercranially. For the extracranial reconstruction, there are different procedures. So you can have different procedures in terms of trying to make some kind of nerve transfer practically in terms of reinnervation of these nerves, but this is also not so common. This is most common for the facial nerve. So you have a hypoglossal facial nerve transfer for let's say one of the standard procedures in terms of facial nerve repair following vestibular schwannoma surgery or other type of lesion, or you can have some kind of grafting procedure, cross-facial grafting procedures from a contralateral side, but this have to be carefully evaluated and planned for each individual case.
Thank you very, very much, sir. I think this is the last question over here. So thank you very much for your very elaborate answer. And everyone really wants to, see your lecture again on YouTube. Everyone really wishes to have the privilege of reviewing your lecture. It was so insightful. Thank you very much, sir. Sir, just one more question from the audience. What is the effect of and the significance of the DASH score in comparing nerve repair graft in terms of long and short distance from the site of nerve injury?
Please repeat one more. Slowly.
Yes, I think it's a long question. So it's okay, sir. Thank you very much. I believe there is a lot of net connection issues, but sir, I really wish to share a news with you, sir. I have just released a book which I really wish to share about. And sir, this is a picture I really wish to show everyone because I have placed it uh, in my just a moment. I think my
Can you
hello,
can you repeat the question slowly?
sir. Just
Hello, Maria. Noor.
So actually, I'm having a little bit of a net issue over here, like I have mentioned. Sir, I was actually meaning to share a few words about. I really wish to share the news with you as well that we have just introduced, I and Professor Luis Borba have introduced a book on basic neurosurgical approaches, and we are like quite happy and I really wish to share this news with you as well because it's something that we.
Ah, you are losing it. No. In the meantime, I don't know if you can hear me, but generally speaking, there was one question which I saw in the chat, which I consider very important also. It is okay. There is a question: what is the effect and what is the effect of and significance of DASH score in comparison of nerve repair graft in regard to long and short distance from site of nerve injury? DASH score is and Ulm score are scores for evaluation of the quality of life of the patient and the quality of
Sir,
recovery.
sorry, there was a net issue, like I have mentioned before, from our part of the world. Sir, big thanks for joining us today, sir. Thank you very much for your time. We have some net issues right now, but again, I'm so sorry. My apologies for this inconvenience that has been caused. We have a firewall installed by by our government right now because of some security reasons. So I'm sorry for this inconvenience of our internet connection currently. So again, sir, thank you very, very much, sir, for your insightful talk and for the wonderful discussion session. So thank you very much, sir. It was an honor to.
No, Maria, you are again out of range. Hello. Anyway, the DASH score is a useful score for evaluation. This is the answer on that question. And there is another question which is how long one should wait to confirm the results of nerve repair was successful or not, and can one do a second surgery with a different procedure at the same location? This is very important question. Maria, can you hear me? I cannot hear you. You are mute, Maria. Noor,
Yes,
you
sir.
are mute.
Thank you
Yeah.
very much, sir. Yes, exactly, sir. I'm really, really sorry. Like I have mentioned before, we have some internet connectivity issue from Pakistan. We have some, due to security reasons, we have a firewall installed on our internet. So I'm sorry for my apologies for the inconvenience caused. Again, sir, thank you very, very, very much for this insightful talk and for this discussion session. We have taken a lot of time from you, and I know you are so busy today with your conference in Argentina. So, sir, please accept my wishes for a wonderful conference today in Argentina. Thank you so much, sir.
Thank you for this kind invitation and possibility to present some of my and our experience. As I said, I hope this will be useful for the audience, and congratulations for the organization of all this. I just want to answer on this question, which is very important question: how long one should wait to confirm the results of nerve repair was successful or not, and can one do a second surgery with a different procedure at the same location? The answer is you have to follow your patient after surgery periodically, which means first checkup is on fourth month after surgery, and then you can have some. You will not expect clinical recovery, but some EMG signs of regeneration can appear. And then next one is 8 months. So between 6 and 8 months, you will have clear signs of initial recovery, and then recovery will continue, and then this is okay. This is recovery will be up to M3, M4, M5. That depends on these different factors. But this is not for the redo surgery. Your question is about redo surgery in peripheral neurosurgery, which is also a very important issue. And usually, if there is no signs of recovery between 6 to 8 months after nerve repair, you can do redo surgery. If you have a possibility to use some other sources for regeneration, you can do it, but you cannot do same nerve repair type of nerve repair. For example, if you are perform grafting, to perform again grafting, because you will have a longer nerve defect. You have to resect all these segments, and then you can do it in some moment, but generally it's better to find a way to regenerate this in terms of nerve transfer. But this is usually happens that when the sum of nerve repairs are doing it in terms of in unexperienced hands. If you are experiencing these circumstances, you should not be scared about unsuccessful nerve repair, because if you do surgery completely, in some very rare situation, you will not have any signs of repair. So thank you for this question. This is very important question for everybody. Maria, can you hear me? Yes, you are muted. Noor.
Yes, yes, sir. Yes, I can hear you, sir. Thank you very much, sir. You have I've been seeing that you have answered in almost every question there, and I think that this talk is really going to be a treasure for us. And already many viewers, they are asking me if they can see it, if they can learn more from it. So again, sir, I believe, thank you very much, sir, for this amazing talk and for your time. And my apologies for the inconvenience caused by my internet connection.
No, Maria, thank you very much. You can please copy this link also to me on a WhatsApp. And I was running a little bit this Q&A chat while you have a problems with the internet. So I hope that we answer all questions. I see one more question about do you encounter a lot of iatrogenic sciatic nerve injury by injections? And if yes, what is your management methods? Not so many, but they are not so, let's say, rare. Usually, starting with the careful anamnesis and evaluation of what patient received as therapy, because that depends if there is a chemical injury or direct needle injury. This is another approach, but follow up for some period within 2-3 months. If the symptoms are not diminished, then I usually explore the sciatic nerve, and this all finished with neurolysis. But the big issue is when you have a sciatic nerve needle injury, I mean iatrogenic injury because of the injection. But following this, you have a motor lesion, motor defect of the tibial peroneal nerve. This is very then complex for resolving, because high proximal lesion of the sciatic nerve are not very favorable for reconstruction in terms of nerve grafting, and there are not possibility for nerve transfers in this level of the injury. So usually this finish with neurolysis. That was the answer. So we answer all questions, I believe.
Yes, exactly, sir. I think that there is no question left in the chat box again. So thank you very much. Yes, you have answered all the questions that have been there in the chat box, sir. So this means a lot to us, because this means so much, and I believe that you have shared almost every important thing that we needed to know. So again, sir, thank you so much for your time and for sharing your wonderful, your impeccable knowledge with us, all of us, which means so much. And you are a real inspiration for me and for everyone who is watching today's webinar. Thank you so much,
Thank
sir.
you. Thank you. So we are finishing. Goodbye to everybody, and hope to see you soon somewhere in Europe, in Balkan, in Belgrade, or everywhere in the world. I am on your disposal, whatever you want. All the best.
Thank you very much, sir. All the best and have a wonderful conference ahead in Argentina.
Bye bye.
Bye, sir. Thank you so much. Thank you, everyone. Bye bye.